This is Bolus Maximus. I'm Brandon.
And I'm Matt. Thanks for tuning in.
This is my first time hosting a podcast. How about you?
Yeah, for sure. Any idea how we're supposed to get people to listen and subscribe to this podcast?
Just by saying it?
Subscribe.
You're tuned in to Bolus Maximus with Brandon and Matt. Don't forget to comment, share, and smash that like button to stay up to date.
All right, welcome back. Thanks so much for joining us. My name is Matt Taro. I am here today with a very special guest and my co-host, Brandon A. Denson. What's up, Brandon?
Hey, how's it going?
It's going well, man. We are joined by Michael Castagna, just like lasagna. I wanted to make sure I said it right. Has had to say it right away. Michael, thanks so much for joining us. You are the CEO, the Chief Executive Officer of Mannkind Corporation. We are super excited to have this conversation. How you doing today, Mike?
I'm doing great, man. It's a great sunny day, and it's getting ready for winter around here, as we all know, and happy to be here. And thank you for inviting me to join you guys today.
We appreciate that. Funny you say winter, as we're all on the West Coast here. That means about 55 degrees. Far cry from where you grew up on the East Coast, yeah.
Yeah, I think all of us know the cold weather. So the California winters are tough. I have to tell you, after my 8th one this year, I'm not sure I can survive.
All right, so if you wouldn't mind, Michael, would you give us a little bit of who you are, where you grew up, and a little bit about your background, please?
Sure. I grew up in South Jersey, Philadelphia area, so you'll hear my Jersey slang, Philadelphia slang when I say water or tomato. But I went to school. My background's in pharmacy. I'm actually a doctor in pharmacy. Went back and got a business degree and have built a career here in the pharmaceutical industry. I've always worked part-time as a pharmacist up until about a decade ago because I just wanted to always understand what the patients go through. And when you work in a pharmaceutical company, not everyone's a healthcare professional. Not everyone has ever lived with diseases or understands what a patient journey is, or when you go to do that transaction and pay a copay. I see patients filling 7 to 10 drugs, and I'm like, any one drug's $20, but 7 is $150, right? Like, that's a lot of money. And people say, oh, my drug's only $25, right? So it was always helpful to have that perspective. And I built my career actually in HIV. So this is at a time frame from 95 to 2005 when people weren't living very long. They were very sick. They were on lots of drugs. And so I enjoyed watching us transform that particular disease in my career. And then I built a successful career in the pharmaceutical industry. I'm going on my 23rd year. I guess I just had my 23rd year. I'll be 24th year next year. So
congrats.
You guys celebrate anniversaries. I celebrate my career lasting in the industry. But this has been a phenomenal career when you can transform diseases like HIV and cancer and diabetes. And everything I've worked in is about innovation and transformation. And I mainly do turnarounds. And so I joined Mannkind about 4 years ago when the product we have here didn't launch well, and we got it back, and we were able to transform a $2.2 billion 20-year investment in innovating insulin, which is hard to do. We'll talk about that today, but that's really what I joined, and then I became CEO about 3 years ago, and it's been a just phenomenal journey, and we've gotten so much more data out and understanding of the product and how to use it, and we've been successful every year. We continue to grow. We want to grow faster and help more patients, and things like this, letting us get out there and talk to you guys who influence the community, allow us to give people perspective on options and answer questions. So that's my background. Love healthcare, love pharmacy. Worked on bringing Omnipod from diabetes over to cancer for Amgen. That was one of my last jobs before I came here. So I love doing cross nature collaborations and bringing innovation into the marketplace. That's what gets me up every day.
You're talking to a couple of hardcore users right here. We've been in, respectfully 17 and 18 years with diabetes. Brandon and I have both used Afrezza. I used Omnipod for a while, so I don't have my Afrezza whistle. It really is. It's great. We'll get into that. What we'd like to do is a quick icebreaker. We want to give the listeners here, thanks everybody for tuning in again to this podcast. We want to give everybody an opportunity just to learn a little bit of who you are, like a background, right? We just heard all the front end stuff, who they see if you're behind the counter at the pharmacy. We want to learn a little bit more about you. So Brandon and I are going to do a quick fire round here, and I'll let Brandon kick that off.
All right. Are you ready?
These
I hope so.
These are this or that. These are all like this or that. It's like one or the other. So you got to pick one or the other. All right, Brandon.
All right. Let's jump into this, Mike. Flip-flops or golf shoes?
Flip-flops.
All right. Cake or cookies?
Depends on where the cake's from and the cookies. So chocolate chip cookies any day. Nothing but cake here in Thousand Oaks any day. So in general, I'll pick cake though.
Okay.
Picnic or barbecue?
Barbecue.
Sand or snow?
Sand.
Eagles or Phillies?
Eagles, Eagles.
Hall and Oates or Jim Croce?
Oh, I don't know. Keep going. Next.
All right, give him the next one.
The Roots or Will Smith and Jazzy Jeff?
Will Smith and Jazzy Jeff.
Ice cream sundae or ice cream sandwich?
Ice cream sundae.
Follow change or create change?
Create change.
Sports car or truck?
Sports car, if you know me.
Wine or whiskey?
I am probably a beer guy, but I would go with wine over whiskey.
All right, and then this is a three-parter here. Book, music, or meditation?
Music.
Okay. All right. Can we go back to Hall and Oates or Jim Croce? Did you grow up with those, with listening to those? Or Brandon didn't know if I should ask that question. I said, if he's from Philly, we're going to ask that question.
I'd probably go with Jim Croce if I had to, like, if you forced me.
Okay.
We don't want to force you to do anything.
All right, everybody, you heard it here first. Well, we appreciate you answering those. All right, so growing up, you have tackled in the last couple of years. We'll get right into it. You tackled in the last 10 or 15 years a lot of the biggest issues that plague, if you will, human population, between cancer, between AIDS and diabetes. Those are the three leading in a lot of people's minds, illnesses, ailments, diseases that people live with, that there's not always a positive outlook. So starting off in pharmacy, what was the first profound thing you learned about patients? What was the biggest thing that helped, like the turnkey moment for you, learning something about patients, as you said you wanted to get into?
Yeah, I mean, for me, I was a kid I was the first to graduate high school in my family. I had no father, so just having role models and just knowing where to go in life didn't exist. And so someone got lucky in high school to have a good professor and got into pharmacy school. I couldn't even get into pharmacy school today if I tried. So the fact that I got lucky to get in, I'm just thankful forever for my college. But I took advantage of that. I'm a hustler, right? So I always got to figure out how to survive against all odds and work my way out of situations. And that's what we've done here at Mannkind. It's what I've done in my turnarounds. And so when you think about like patients, the thing for me is when you're diagnosed or you're going through a doctor's office in a 15 to half hour visit, they're talking to you and all you're hearing as a consumer is want, 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 want. And then you leave and you hope you're going to read whatever the hell they gave you. And you hope you remember and you hope the instructions on whatever product were right. And then you're reading stuff today on Google. 25 years ago, you couldn't do that. But consumers are, able to go find more information than ever before. But years ago, they don't know what drug treats what condition. They just know I got a blue pill for this and a circle pill for that. And I don't know which drug it is. I just know the color. And then when generics started coming out, people are like, I don't know, now it's yellow. What happened to the blue one? It's the same drug. Well, now I got to change my mind. And, while everyone's saving money, people lose what drug they were taking. They get confused. And I'll never forget, like when I worked in HIV, a lot of indigent patients, minorities, I worked with the gay population, and people were very biased towards an uneducated person and what they did or did not know about their disease and their compliance. And it was really, they were prejudging, sometimes they're homeless, sometimes they're drug addicts that had HIV. And I have to tell you, those people knew more about their drugs and were compliant than some of the richest people who had all the support around them. And I was always, wow, education level does not correlate to success. And that was like a good lesson when I worked in the communities dealing with people. And I just remember, like, I was just one patient, couldn't read or write. He knew he had to take 5 blue pills twice a day of the one and one of the other one. He knew that. And yet I could tell you 20 other people who had all the right education, couldn't remember which drugs to take and what regimen. And so I say that because I saw an HIV, and the good news, look, we've made this a chronic condition. I never want to minimize any disease people live with, but when I left HIV in 04, 05, we got a tripla, which was 1 pill once a day. That was my last deal that I worked on when I left Bristol Myers. And I remember saying, wow, we got this down to 1 pill once a day. People living with diabetes have way more of a complicated checking your sugar, timing your insulin, multiple pills, multiple copays, needles. I mean, it's way more complex, right, in what you do. And then you got the risk of death because of your insulin. So I looked at HIV and I started, I was in sales for a couple of years. And I'll never forget, in Africa, the HIV is decimating the population at the time. And one of my buddies started a nonprofit to donate expired drugs to Africa because something was better than nothing. It's called the Starfish Project. It was run by a doctor named Brian Boyle. And he said, Mike, will you put boxes in all your doctor's offices and collect these drugs so we can package them up and ship them to Africa? And I said, I'd love to. Let me see what I can do. So I asked the doctors. They said, no problem. They advertised to their patients. We collected $300,000 in drug
Wow.
in literally 2 months.
Wow.
Patients were bringing in 5 and 10 bottles of the product that they were filling at the pharmacy, putting in their fridge or whatever, and never taking the drug. And that was the biggest profound impact I had in my career, which is doctors had no idea patients were afraid to the patient was afraid to disappoint the doctor, to say, I'm not taking that drug because it causes diarrhea. I'm not taking that drug because my leg hurt when I took it, right? Whatever the reason is. And they would pretend they were taking it. What would the doctor do? Your viral load's high. It's not working. Let me change the drug. Let me put this other test in. And they just assumed because the guy was educated, he was taking his drug. And then the other guy who probably was compliant, got ignored and didn't get to the doctor every 6 months, but yet, they fall out of treatment more often because they just don't have that support network. But these doctors often will, cross the diseases I've been in. I've been in a lot of diseases, not just the 3 you mentioned, but I see similarities, which is, as a pharmacist, they just increase the dose, they change the drug, but they actually don't ask the fundamental questions. Are you understanding why you're taking this drug and the value it's bringing to you as a patient? And that was important. So for me, when these doctors started changing, they would just change all these regimens, and they didn't realize that the resistance wasn't showing up because people just weren't taking the drug. And so the compliance aspects and the knowledge of why people aren't compliant is a lot about education and setting expectations, i.e. this drug may have this side effect, and if you have it, let me know, right?
Yeah.
Maybe we can help treat it. And many times patients they're not confident, right? They don't want to disappoint their doctor. They put doctors on pedestals, and they don't want to hurt their feelings. And you live with the disease. I tell anyone I know, you live with the disease. You're not happy, fire your doctor. You get the best care you can until you're happy.
Amen.
And that's the reality.
No, and that's real, because, man, when you say, if you're not getting what you need from the doctor is supposed to put you on that best track possible, far as care, far as just being able to spend that time, that time that you need to make adjustments. And, dealing with diabetes, there's so many different things that come into play, basal rates, boluses, insulin sensitivity factors, so many different things. And we're not even talking about the aspect of you having to check your blood sugar, or even if you use a CGM.
Right.
Excuse me. But, the main thing is being aware, like you said, it may be that person that doesn't want to talk about the side effects that a drug may be having on them, but the person that actually needs it can't get access to it. But I'm gonna kind of shift gears a little bit, because I want to hear from you in regards to far as how is Afrezza going to kind of shake things up, possibly between other insulin companies and things like that, because, to be honest, none of my endocrinologists have introduced this drug to me. It's been from the diabetes community. And when I say it works wonders, it does. I'm not a licensed professional. We are not sponsored by Mannkind. But for me, anytime that I've used it, for the most part, it's done what it's supposed to do. And, I kind of use it in a different way probably than other people use it. I also wear a pump. I wear an insulin pump. But if I tend to go high, I like to use the Afrezza, so but how can we, what's on the horizon far as what we're going to see far as, as this continues to be more mainstream of insulin, how's that going to affect the community?
Yeah. No, I think anytime you're disrupting 100-year-old market, it takes time for the market to adopt something, right? I think about motor cars, right? I love engines. I love sports cars, but Elon Musk came out with a phenomenal product, right? You can't argue with Tesla's a pretty cool car, lots of neat features, lots of good technology. And yet, if he had waited for gas stations to build charging stations, if he had waited for the distribution network and the unions to come his way, if he had waited for auto body shops, he would have never survived. And by the way, it took him 10 years at least from where Tesla started to where it finally started making more than a couple thousand cars a year. And you needed tax incentives, and you needed, he charged a friggin' boatload of money the first, $100,000 car. When I moved to California, I couldn't believe how many people could buy $100,000 cars. But they look like they're Volkswagens around here.
Right.
And but he built the charging network. He built everything to disrupt the car industry. Now look what's happening 5 and 10 years later. Everyone's moving to electric cars. And the good and bad news for Mannkind is, we've spent $5 billion between us and Pfizer bringing a new innovative insulin to market in terms of inhaled insulin. Pfizer gave up. I'm not sure that product would have succeeded. Not that they kept going. I mean, it was a huge bong and didn't really provide any clinical benefits relative to injectable insulin. Where with Afrezza, it's a very different product than the Pfizer one. It was made differently. It acts differently. It's a very scientifically different product. But the fact is, changing route of administration just from an injectable product for 100 years took $5 billion in 20, 30 years of research. And in our case, probably if you put both companies together, we probably almost spent 15,000 patients in those trials. And so when people ask about the cost of drugs and why is insulin expensive, well, look, as a pharmacist, I could tell you vial insulin was $20 and 95. It should be $25 today, right? I'm never going to argue and defend the pricing aspects of this pharmaceutical industry. I understand why it happens, and so we can talk about that later. But at the end of the day, nothing's changed about that vial of insulin in 20 years. And so, that should still be $20 like it is at Walmart with Relion. And we'll talk about that today. I think that's an important topic. But when it comes to something that's innovative, that's different, that there's going to be a premium price for that. And so what's it going to take? Where do I see the market? We're the disruptor, right? Insulin pumps have been working on for 30, almost 40 years now, 80s, 90s, 2000s. Al Mann, our founder of this company, built the pump that most people take, Medtronic. It was called MiniMed. He sold it in the late 90s and took $1 billion of his own money and built Mannkind. So here's the guy who built the insulin pump that everybody's using today, thinks it's great. There's just an ad somebody sent me from 2000 where Al Mann was in the ad and said, the artificial pancreas is around the corner.
Yeah.
That was 20 years ago, guys, probably before Brandon was born. And so, that's how long people have been waiting, and they're waiting for a cure. And I feel bad when I talk to people, because what I see at the end of the day is I don't care which way you deliver your injectable insulin, whether it's a pump, an Omnipod, a pen, the subcutaneous insulin from the time you bolus to the time your food, there's a mismatch.
Yeah.
And you can't solve that mismatch because it's the nature of the injectable insulin. And then when people ask me, like, what's the difference in Afrezza? Well, it's monomeric. And what that means is as soon as you inhale, just like you're putting oxygen in your lungs, you're putting active insulin in your lungs. It gets in your bloodstream right away, gets down to your liver and suppresses something called endogenous glucose production. So that's why you notice, as you said, Brandon, why do my highs come down so quickly? Because we shut down the liver right away from telling your body to release sugar. We do that an hour before the competition. So if you have a race and you got an hour head start, in general, you're going to win. We've done like now several studies, and you see in these type 2 patients, especially, who generally have really high sugars, we're bringing those highs down very quickly in those patients, and we're reducing hyperglycemia dramatically in those patients. And so that's something we're continuing to work on and get the data published out there on the high part. And then on the lows, 1 out of 20 people with type 1 may die from their insulin from a hypoglycemic event. That's really scary and really sad, because it is a life-saving drug at the end of the day. And on the hypoglycemia side, this is an area where, the FDA is very conservative on drug companies, what they can and can't say around this. But, we look at our pivotal trials and all the new data we've generated, we're generally reducing the rates of severe hypoglycemia dramatically, and, statistical differences than the standard of care. And so why do most people not get in control? It's because you're afraid to push your insulin dose, because you're afraid to go low. Mm-hmm. And therefore you're going to go higher than you're going to go lower. And with Dexcom, you can see your sugars, but we have less hypo, but we have more hyperglycemia happening, because now people wait for alarms to hit before I take action. Like, okay, I'll set it at 150 or 180, but that's when I now take my insulin, right? So now we got more people going high longer, and we avoid lows, but then A1Cs have been creeping up when you look at the databases. And so that's a long answer for a short question. But I think when you're disrupting something, it's going to take time. We're here for the long run. Afrezza, Mannkind will be here for the next 15, 20 years. We don't see anything coming that's going to come close to the technology innovation and the research innovation that we've done. And, it takes time to get doctors on board. But you're right. Doctors are one of the barriers to success. They just have to listen, read the data, and understand the data, and try something different than what they've done.
It's like saying you can't teach an old dog new tricks, but at the end of the day, we have to be able to, these professionals, they have to be able to, medical professionals, they have to be able to adapt, because it's not about what's the best thing for them. It's what's the best thing for the patient,
So I got a puppy instead, and then I trained the puppy. But no, I mean, but on that note, right? We're going into we're filing a protocol pretty soon with the FDA for pediatrics. Yep. And so to your point, when you can now have a kid grow up who's never been on injectable insulin, right? Maybe a basal shot, but if they can start out on just inhaled insulin and grow up that way, and the doctor starts to say, I want to put you on injectables, I want to put you on insulin pump, they may say no. Right? They may say, wait a minute, I don't want to wear something and change it every 3 days. I was doing fine. And that's, to me, what you're going to do. You're going to transform the standard of care over the next 40 years by helping kids show a better way to treat their sugars. And then they grow up and they'll go into the adults, and then adult endos will learn. But that's how insulin pumps got started too.
Yeah.
Insulin pumps, kids grew on, the parents cared a lot about continuous infusion, and then the adult endos started to get on board. It wasn't driven by the adult endocrinology, so it was driven by children.
You guys are already making a hell of a. Oh, go ahead, Matt.
I was going to say it's an interesting method of adoption, because look how long it took for insulin pumps to really become mainstream with a lot of patients. A couple of years ago, it was still the majority of people still did MDI, right?
Yeah.
And or didn't use any form of technology to manage their diabetes. And the more and more people, I think that Afrezza will really step up in an incredible way for inhalable versus injectable, because of what you just stated. So that's great to hear. Appreciate that information. So thinking about, I heard you say a couple things in there. BMS, I used to do advertising for BMS. I think one of the easiest ways for people to understand how crazy the landscape is with a lot of those drugs is to look at type 2 diabetes and look at the amount of inhibitors that are on the market. And if you fail one, you go to the next. If you look at this, you go to the other. There's so many different drugs out there. I've asked type 2 diabetics, what are you taking now? Not what are you on? What are you taking now? I've literally only ever injected one type of insulin, and I have inhaled. I've inhaled Afrezza.
Inhaled what? Okay, make sure.
Times, yeah. So, that is my goal, is to help more people understand that. I think what Brandon and I have done with Bolus Maximus, or what we're trying to do in the long run, is to help bridge that gap for the individuals you just mentioned, people that don't know about what your options are. We want to make it very apparent, and not because we're trying to sell anything, but more so because we're users and how much it's benefited us, And
I think something what you said, Matt, to piggyback off that, the type 2 community, a lot of people hear type 1 diabetes, but type 2, it's 34 million people diagnosed with type 2 diabetes, pre-diabetes. So these are large numbers. My mother has type 2 diabetes, and, we look at what we see her take metformin or these other medicines in a pill form. I think she will probably get a lot more out of just, inhaling something, which would have the same result as taking a pill.
So just when you, what do you think the first defect is that shows up in somebody with type 2 diabetes? It's their fasting insulin, their fasting sugars, or their bolus sugars, their mealtime?
Oh, mealtime.
Right. So 1976, 44 years ago, we knew that the very first thing that goes in type 2 diabetes is your insulin response, your mealtime insulin response. People that gotten pancreatic transplants to try to get their pancreas with insulin again, the first thing that goes is mealtime response. And what is the very last thing we give the majority of type 2s?
Insulin.
Mealtime insulin.
Yeah.
Right. We treat, and all we've done is push insulin to the very last step of the guidelines, and we give them, we have a treat to failure mentality by the standard of care that has been done by the experts in this country. When you go back, I mean, why did people start living in 1921 longer? Because we replaced their insulin in the mealtime control. And that's gotten a lot of people to be living 80 years old. Now we got type 2, and we blame the diets, and I'm not going to get into why people have type 2. I'm not here to debate that. But the reality is they have type 2. And the first thing that goes is your mealtime response. And we've done studies to show mealtime insulin actually gives you slightly better results. At the time when these studies were done, there was more hypoglycemia. And so people said, oh, hypoglycemia, let's go to basal. And that became the standard of care with Lantus. And that was a lot of marketing, right? Sanofi built a $7 billion brand on convincing the world that, use basal first, fix fasting first. When the reality is, if it was me tomorrow, I'd be saying, no, fix mealtime first. Even if you only use it twice a day, right? Like just get your sugars under control, because you have a mealtime defect. And I always tell docs, if you have a type 2, like my mom and my family, I'm like, throw a Libre on, you'll see your post-meal spike, add Afrezza, and you'll be fine. I did this study 2 years ago with Dr. Levin in Baltimore. And I said, Dr. Levin, I'm tired of arguing with docs around when do I use Afrezza, where do I use Afrezza in type 2s. I go, let's just do a quick study. We'll add it to anybody that comes in. They just can't be on mealtime insulin. Let's just throw Afrezza on. I don't care if they're on GLP, basal, who cares? 25 patients. We're going to do it in a very simple dosing regimen. It's going to be fixed dosing. There's not going to be all this guesswork on carb counting. In 12 weeks, we got a 1.6 A1C reduction.
Wow.
9.1 to 7.5 in 12 weeks. Had we just kept going, we would have gotten 2%, right? It was a short study. We didn't have a lot of money. But no more hypoglycemia, by the way. So we got a 1.6 with no additional hypo. Hyperglycemia dropped 75% almost. And time in range increased by 5 hours a day. So, now it's a small study. But any doctor could replicate this in their own practice.
Yep.
It's insulin, guys. Like, it's about getting glucose under control. It's not that complex. Like, why aren't doctors reading the data, making these decisions? And what they'll do is they'll add a third and a fourth drug to these patients for the next 2 years. They'll get more damage on their kidneys, more damage on their eyes. And then they'll say, oh, now I need to put you on insulin. They could have stopped that 5 years earlier. Right. And this is where
but when we look at something like that from a doctor's perspective, like we said, like they're there to treat the patient by what they need. But why is that not being done though? That's what I guess that's what frustrates me, because it's like why aren't they doing the best, like practicing the best practices, if that makes sense?
I think the problem with healthcare, right? I'm the one guy, I'll tell you, in this whole industry who tried to build biosimilars over 10 years. I did them for Novartis and I did them for Amgen, and nobody wanted to save money in healthcare. Like, I would go to the large insurance companies and say, I could save you 20 million. I go to the government and DOD and say, I can save you 40 million. And they say, oh, I could do that by just getting a bigger rebate on Prilosec or something. Like, people don't have incentives to actually drive down cost or improve outcomes. And when you go to a doctor, what's their incentive? To see you for as least amount of time as possible, to get you in and out the door, check in, make a small tweak, and have a good day. Because whether they spend 15 minutes with you, 10 minutes, or a half hour, it's $20, right? They're not making a lot of money, and therefore the only way they stay alive is to see 5 patients an hour, 4 patients an hour, and therefore you don't have the quality, right? And I say, like, what if, like, when I talk to doctors, they say, Mike, Afrezza, it's a lot to learn. I got to change what I'm doing. It's all about them. And I go, but don't you have like 20 people a day coming in not in control? Because that's, the data says 8 out of 10 people on insulin in this country are not a goal. So when you tell me that you're not doing anything different, I'm saying 8 out of 10 nationally are not a goal. So therefore, I've gotten in trouble because I'll go to a diabetes clinic and they'll say, Mike, I just haven't found the right Afrezza patient. And I usually lose it when that happens. And I said, I'm sorry, am I not in an endocrinology office? And they go, well, yeah, why? I go, oh, because we're indicated for type 1 and type 2 diabetes. And so I thought, when you're looking for the right patient, I thought you would treat diabetes, but I've gotten thrown out of offices for doing that. But it's true, right? Like, you're looking for the right patient. 8 out of 10 that come in on insulin are not a goal. What more do I need? Now, if they have COPD, if you have asthma, you're not the right patient for our drug. And I fully acknowledge our limitations. But in general, right, if you don't have underlying lung conditions and you don't smoke, this is a good option for you to consider, and let the patients decide, right? And provide them options. But
give them the information and see what they come back with. I like even more here, and you get thrown out of a doctor's office, Mike. It's
only happened twice out of like thousands, so it's not. My rate is pretty low, but
those are good odds.
yeah, I like it. So I think you've made a lot of really good points, and you've talked a lot about what the need is, and I think people who are listening to this may be a family member, maybe a clinician, maybe a patient themselves. It's a lot of the patients doing a lot of the legwork in diabetes, right? We said this before we started talking. It's a very self-sustaining disease to live with, right? We do everything for ourselves. Most of the time, a lot of the patients that I speak with, they go, oh, well, I'm going to go to the doctor just to get a prescription and then come home and do whatever I want to do. And they end up doing better off than listening to the doctor who doesn't really know that much about what's going on. So can't wait.
I think we're saying nowadays that, a lot of people use this as taking the middleman out of things. And, obviously I'm never going to advocate don't go see an endocrinologist, but I think what we're noticing nowadays that we have the data too to make the corrections on top of when we go see an endocrinologist. And I think if you're able to read that data accurately, just like an endocrinologist should be able to do, or a doctor or whoever you see, you can make some of those adjustments too. But I think having Afrezza makes things a little bit more easier far as being able to make those quick adjustments as well.
So both of you live with diabetes. How many times have you walked in with your doctor, you educated, and they sat down and printed out your CGM and said, let's walk through and talk about it? I mean, has that happened once a year, once every 2 years?
3
Never.
times a year, and you're like
a couple. It's supposed to happen a couple times, but
how often does it happen though?
rare. I mean, what I had a
If you're
phone
calling
call.
and asking, it's happening. But how many times have
Yeah.
they said, "Hey, Brandon, I was looking at your CGM. I printed out this thing, and let's
Nah,
talk about this."
I'm not. Yeah, only when I go in are we
Right.
discussing those numbers, which they have access to those numbers because they have a code where they can see it. So
Right.
that. Yeah, you're
We're
right.
spending $2 billion on Dexcoms a year, another couple billion on Libres a year, and Medtronic's sensor, so that doctors can do better care and educators can provide better insights.
But it's not
And
happening.
it's not happening, right? And so COVID hit. Look, for me, and I can tell you my vision. My vision is we will transform diabetes by transforming the care model of diabetes. I don't think the system is broken in healthcare. There is no incentive for them to get better outcomes. There is no incentive for people to spend more than 10, 15 minutes with a patient. I had one doctor, one of my visits, say, "Mike, the guy down the street who's a shitty doctor makes more money than me because his patients are out of control. And therefore he builds higher visits because they're more complicated visits. Where if I do a great job and all my patients are in control, I actually make less money because I'm doing a better job." How screwed up is that system?
It's
Right?
hard.
I mean, right. And this guy cares about his patients, so he spends more time. He makes less money because he cares. And I'm not going to say most doctors don't care because that would be really crude, but doctors go into medicine for the right reasons. And unfortunately, the practice of medicine these days is not driven by care. It's driven by money, right? It's driven by times and slots. But COVID, I think, has done a miraculous job to take old dogs and new tricks, meaning all of a sudden, how many times you're doing virtual visits? You're saving hours in your life every quarter. They're saving time. You're getting probably a little bit more quality visit. But now they're learning how to look at CGMs, right? They're learning how to think about that because how do they really coach a visit if they don't know your sugars? So I
But
think it's been a
they're
good thing.
forced to. They're forced to
Right,
now.
they're forced to. And when I talk to a doctor and they say, "Mike, I don't know this Afrezza." I'm going to ask both of you. When you take Afrezza, do you carb count and try to figure out what dose you're going to take?
Yeah.
Right. But are you carb counting or are you guesstimating? There's only 3 doses.
I'm guesstimating.
You're just saying, "Hey, I think this is an 8 or I think this is a 4," or
Yes.
right? I mean, you're not like doing all this complex math in your head and then converting it and then multiply. Are you? I'm asking.
No.
And so I'll say to docs, like, our patients don't need the carb counter educator, and their head pops off. You can't say that. I said, we've done 70 trials. Name me one where we've carb counted. I can only name you one. We're about to publish the data. It happened 10 years ago. But the point is, we have already done this in thousands of patients where we're not carb counting and dosing insulin. We convert you from whatever dose you were on injectable insulin to take our product, or we give you a fixed titration regimen to follow your glucose. But we're not doing all this complex math. We're not trying to time your insulin before you eat. And it's very simple.
If you said that to parents, though, so you mentioned before, and I think this is a really great segue, we're talking about Afrezza, the pediatrics. I mean, if you said that to parents, they'd come after you with pitchforks, especially
educators come after me at Pittsburgh. I've had doctors like, "How can you say that? My whole job is to teach you how to count carbs." I go, "I know. And you got to learn how to retool yourself. And just how, if you spend all that energy on counting carbs and insulin sensitivity ratios and insulin on board, and you just said, look, when your sugars hit this, let's get your own PK on Afrezza and know that a 4 unit is generally going to drop you 20 or 30 points and an 8 unit might be almost double that. But let's figure out your own ratio on Afrezza. And then when you're high, okay, you're going to know to take a 4 and 8. And if it's a meal, you're going to guess, you're going to get pretty damn close. And then you know what? An hour later, you can correct it if you're off."
I mean, carb counting is still important. It's still important to know what you're eating. I mean, let's say that. But at the same time, I think you make a great point there. It's a lot of guesswork. Yeah, I didn't want to say that publicly. You got
Don't
me.
worry.
You got me.
So quick question. When we look at in regards to like the pediatrics, do you think that it would be harder to convert a newly diagnosed patient with diabetes to Afrezza, or would it be probably harder for somebody that's already been living with it for multiple years over to Afrezza?
So the first one's going to be the doctor, right? If the doctor says to a kid, let's fast forward, we don't have an indication for kids today, right? I just got to state that in case the FDA wants to listen to this. But let's assume we fast forward and we're launching Afrezza and it's approved. It's really going to be the doctor. If the doctor's convinced of the data and the safety of the product in kids, then they I don't know if you guys know this, but doctors make money when they prescribe insulin pumps, right? And so, sorry, Matt, I know you work for one of the pump companies, but and that's okay. But you don't sign a release as a doctor saying, "Hey, by the way, I'm going to make I don't know, $300, $500, but every time I train you and you come back to my office, I'm making money." You don't get that for Afrezza. And so I think if we put that away to the side, and that's what I was going earlier with my one comment, if you invested all that time, the 3 visits on training a patient how to use a pump on how to properly dose Afrezza, you would get there. You would figure it out very quickly. And that's the same thing with kids, right? They're bringing these patients in, they're going through 3 or 4 training visits. You got to make sure they're comfortable in MDI. That's a lot of work for a family. And if you were to invest that same thing and be convinced that this would be equally as good, then it's going to be the doctor. I don't think a parent's going to come in and say, hey, I want that inhaled insulin. I just don't see it. They're going to lean on the doctor for a naive patient. Someone that's living with the disease and a kid who's got their friend on it and they're going to camp and they're seeing what they're doing and they're running around, they're swimming and playing basketball or whatever. I think that's going to be a different story. Like, hey, I want that lifestyle. I don't want to have to take my pump off and run away and then come back and I'm high and I got to get it back on. And, it's a lot of stress on somebody. And so I think there's going to be 2 different camps there. And then there's diabetes burnout, right? The teenagers are revolting. They don't want to wear anything. They don't want to listen to anybody. They want to be on their own little world. And, they'll think it's cool to be inhaling, I guess, so I think we got a couple of years to figure that out. That's the good news. But,
Sure.
Yeah,
as long as we don't mistaken us for cannabinoids beef.
Yeah, no, I got you. And I've worked at camps for kids for a long time. And I think that, it was really easy for Omnipod to be pushed towards parents who had young children to say, well, they don't have any tubes, right? So it's the easiest option. And this next thing you know, you're speaking to a patient who's used Omnipods for 10 years and like, well, I'm just used to it. It's like, well, there are other options out there, right? There's other stuff.
They grew up with it and it's good and it's working. Like, and that's if whatever your regimen's working, great. Like, I didn't tell this earlier, but like I didn't have a dad growing up, but when I found out who he was, he had passed away from complications of diabetes, right? And he didn't take care of himself, from what I hear, right? And it's sad and it sucks, but that's life. And that's why I say, like, as long as you're in control and you're going to live a good life, if you're in control and you can live a normal life, but when you're not in control and this disease attacks you over 20, 30, 40 years, it's a shame because you feel good when you're 20 and 30, but when you hit 40, 50, 60, it catches you. So, that's why I remind people.
We like the new way. We like the innovation. I'm digging it all the way.
So what's on the horizon then? You mentioned the pediatrics, but for Mannkind, it's a large corporation. You guys are doing a lot other than just Afrezza. There's a lot of other things on the pipeline, phase 1, phase 2, that's coming. What's in the horizon for you?
Yeah, so when we look at the world, one, I think you can see my little device on our Zoom meeting. I got this little adapter on the back of the device here.
Okay.
It just clicks on, and we're using this for 2 reasons. One, proper inhalation technique, because you get the drug, you take it for the first time, and you don't taste anything, you don't feel anything, and people are like, "Did I get it? What happened?" So this device will actually train you properly. That's just launching as we speak right now. So it's got a reader in there. We got an app in the Apple Store, and that's launching with doctors and trainers as we speak. The next thing this will do is actually dose detect. So now when you put a 4, 8, or 12, it'll know whether it's a green, yellow, or blue cartridge, and we're going to sync that up with your Dexcom and show you on your CGM, like, hey, I took, because I don't live with diabetes, but I do take Afrezza sometimes because my pulse parameters are high. And I started, I wear Dexcom, I've worn Libre, and I'm like, wait, I'm trying to simulate what it's like living every day. And I'm like, wait, I think I took it at 6, but maybe it was 6:30, and I think I took the 4, but maybe I took the 8 because I already threw out the cartridge, right? Yep. And you realize, like, you're human beings. Like, you guys aren't, like, when people sit in drug companies, like, oh, well, patients got to know they took a 4 unit at this time and they're timing their insulin. Like, no, you're a friggin' human being, guys, and you're busy. And I got 3 kids, and I'm running around. I'm trying to survive every day. I'm running a company, and you guys are busy as well. And so people, they're just guesstimating life. You're trying to, I took it around 6. Might have been 5:30 because we all lose track of time. And that's what I think this is really going to help. You just double check, like, oh yeah, I took a 4 instead of an 8 and I'm high. And now I know it's been an hour and a half. Okay, Afrezza is generally out of the body by then. Let me take another dose, right? So it's going to give you a lot more control, a lot more insights. And when we start collecting that data, then the version 3, the one after this first dose detection, we'll start to do prediction, right? So we'll start telling you, hey, every Friday you eat pizza, it looks like, or you eat high, like you take 16 units. Just know that, they're taking 16, consider it, or whatever. However we get that through the FDA medical system, right? But we want to start to get in collecting data and then use an AI to predict, what we're pretty good creatures of habit. Like Friday nights I have pizza with my kids. Like that's generally going to happen no matter what I do. My wife's traveling. I'm not eating a lot.
I'm coming to chill with y'all Friday night.
Yeah,
Pizza's my favorite.
Come on over, man. I got good New York pizza up here.
I like that. Funny you say that though, because earlier today I took some Afrezza. Like I said before we got on the call, had a nice big bowl of oatmeal, and I said, you know what, banana. I said I'm taking some Afrezza. I took a little bit with my pump, but I'm leaning more towards taking the Afrezza now. I took it and I like played it like a flute just to make sure that all of the powder like came in. I was like, this is fun. I got to tell Mike about this. But I also told Brandon yesterday, I just popped it open. I've been popping them open in my hand and just inhaling the small little tabs. So I know that's off label. I want to make sure that everybody understands you should be
Well,
using.
no, we had a person in Europe who lost their inhaler and they were using a straw to get it out. So like it still works. I mean, hey, you figure it out, right? It's life saving. But no, on that note, just that's a really good point you just made, Matt, which is people don't realize in 0.4 seconds the powder empties out of the inhaler. So if I go, the powder's already gone. That quick, it's already out. We tell you to go for 2 seconds just to get it deep in your lungs, right? Because you got to think about a car turning a corner 90 miles an hour is pretty much going to crash. When you inhale dry powdered, Advair's, you're putting that force into the back of your throat that fast, and you generally don't get deep lung penetration. That's the uniqueness of our technology. You probably don't realize this, but in this little inhaler in the back of this thing, you see a little slit mark.
Yep.
That's the harder you inhale, you get more resistance. You're supposed to just inhale slow and consistent, and because we don't want the powder coming out fast, we want it to slow down and go deep and cross all those ventricles. The other thing you realize, if you blow instead of inhale, nothing happens. No, the powder doesn't come out. Al Mann was a genius. It doesn't come out. It only comes out when you inhale. So that, it's got a lot of technology behind the engineering. It seems very simple when you take it, but how you fill the cartridges and how you do all that is amazing. And that's the magic in what we spent $2 billion in 20 years perfecting here. But it gets in there and it works. And then you saw just sucking it out works, right? I mean, I'm never going to advocate that as a CEO. But the drug works when you get it in your lungs and you do well. So that's where we're going is, we think technology and diabetes and integration of that. I talked to Dexcom. I don't want patients to have to go to 3 apps to manage their disease. How do we get everything in one app, right? And I think that's a lot of what I spend my time talking with my industry colleagues of put the patient first and what would you do differently? And instead of everyone's fighting over data, everyone's fighting over their product, everyone's fighting over things in this industry. When I worked in HIV, I sat there and I won't say what year it was, but I said, why are we fighting each other? Like, if you were the patient, what would you want? You would want these two companies working together to put your drugs together, to get one copay and one pill once a day. That's what you would want as a patient. And you know what? We went to GSK and we went to Gilead thinking they'd say no. Both of them were interested. We wound up doing the deal with Gilead, and that changed the future of HIV. Wow. But, as a drug company, I can tell you, if I wasn't there, who knows if that would have happened? I really don't know. But that's something that now sets a standard. Every HIV drug is now in regimens, and then it came out with hepatitis C that way because that's what Gilead did next. And so, I worked on Hep C, and that was the cure that had a bunch of pricing debate. I did that company back in 2005. That was a lot of fun. So.
Not to cut you off, but man, it seems like you're like a jack of all trades, and it seems like you climb that ladder. I mean, obviously you're a CEO, well-spoken, but man, you just say some things that really, really just resonate me about innovation and creating a huge impact. And, I think we see it on a surface level. We see people talking about it, but like, it seems like you're living that, and you can see that through your transitions of climbing the ladder and getting to where you're at. But patient first, I think if any company puts the patient first, I think that company is going to be so successful because there's so many different lanes that you can go. And I'll say it again, something that you said, at the end of the day, you care about the person's health first and foremost, no matter if they're getting Afrezza or they're getting something from Mannkind or they're getting it from another company. You just want to see them live their best life at the end of the day. And that's awesome.
No, and when you think you have the best product, that helps, right? So like I view it as if you want to really get control, eventually you'll get to my product and you'll fight and you get there, right? But at the end of the day, if you're successful in $20 a month Walmart insulin, great. Like, why should you pay hundreds of dollars for something else if you're successful? But if you're not, like I always say, use the cheap stuff first, right? Nothing wrong with that. If it works, why pay for Mercedes when a Ford does fine? But if sometimes you want the lifestyle, you want the convenience, you want other things, it's different. And that's all important. But yeah, I think when you put patients first, you win, and you always make money when you do well by patients. That was Al Mann's philosophy. That's been my guiding principle in my life. And I tell our new employees, whenever you're in a choice and you don't know the answer, just put the patient first, and whatever that answer is, even if it means we get in trouble, I'll never fire anybody for putting the patient first, right? We'll deal with the hits.
That's awesome.
You guys are truly developing life more human.
That's our tagline. You got it.
I had to throw that in there. I like that. I had to throw that in there.
So what would you say, to shift gears again, what would you say far as how is this going to be available, I would say, underserved communities, or let's just say Medicare, Medicaid? You know, as you guys continue to push forward, you know, I think putting the patient first is very, 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 very important. But now, who will actually have access to this Afrezza, and then also, like when we're talking copays and things like that, like what could we be looking at? And I know insurances can get tricky, and I don't want to go down that rabbit hole. But
These are important topics for society, right? So I'll talk about them, right? So. Look, anyone that has commercial insurance pays $15. We have a copay card. You download it. I say if anyone has, like, you work for a company, you buy your, whatever the Obamacare's plan, that's commercial insurance. You should pay no more than $15. If you're paying more than $15, that means your copay card wasn't downloaded or the pharmacy didn't process it. So that's number one. Now we're trying to build out a specialty pharmacy network next year. We already started it this year, so that when the patients come in there, that's going to happen more automatically. So that's because I hate when people say I paid $1,000 or I paid $200. I'm like, no. Like, you can't go back. Unfortunately, once it happens, it's hard. But myself, when I filled my last personal, I forgot my own copay card. I'm like, all right, $65. I'll just deal with it. Sometimes that happens. But at the end of the day, if someone's paying, anyone can afford $20 to $40. I get that, but when it's a couple $100, that adds up when you're on all these drugs. But generally, we want any commercial patient, we buy that down to $15. So that's what I tell patients. Number one, Medicaid patients generally are going to pay whatever the Medicaid rate is. It's a couple dollars or free depending on the state. What people don't realize in society when they argue about access to care for, especially the indigent population that are on Medicaid, which my family grew up on Medicaid. They, in a drug company on insulin, especially where prices have gone up a lot over a short period of time, we rebate practically 100% of that price back to the government. So believe it or not, the government doesn't pay for insulin on Medicaid. It's free. And so when Medicaid blocks Afrezza, we basically give 90% of it back, or I don't know what the exact numbers are, but somewhere in, we give a lot of the money back to Medicaid. And so it's basically free. So therefore, anyone that's on Medicaid and they give it a hard time, that's unfortunate, because it means they're greedy, right? And when I say they're greedy, the government has outsourced, I don't know if it's 60, 70% now, but there's managed Medicaid and there's Medicaid. So like California has Medi-Cal. That's just managed by the government, right? And then you get into, I don't know, I'll pick on a state. Someone else has Perform RX in Philadelphia. They run a lot of managed Medicaid. Perform RX doesn't care what goes back to the state. They care what rebates they get from a drug company. So I laugh because Sanofi recently launched a biosimilar insulin called Andalog, right? They went to the Medicaids and probably gave some discounts because the branded companies don't, because they don't make any money on insulin. And they got thousands of prescriptions because all the payers switched over to the other product. But you know what that means now? The state coffers and taxpayers are now paying for insulin that we never paid for. But now the patient copay is the same. But now as a society, as taxpayers, we're actually paying even more than we would have because of the incentive of a pharmacy benefit manager to collect money and rebates. That's how this game works. And so that takes care. So anyway, long story short, Medicaid patients, generally it's covered. We might need a prior auth, but generally they go through, and there's not a cost to the system in Medicaid. We basically rebate most of that back. Commercial, we talked about, nobody should pay more than $15. And I'll talk more about that in a second. And then you got the Medicare. Medicare is an area we're working on, just to highlight the Trump Medicare for all insulin, $35 insulin. That was done in 1 week. We weren't invited to participate. They specifically wrote the rules that injectable in vial or pen insulin, they excluded the word inhaled, and we weren't even invited to the party. And it's unfortunate. I guess I don't say it's public, but one of the people that were up on stage there announcing this thing is actually on Afrezza, and he couldn't even talk about it because it wasn't in the rules. And then the insurance companies all got together and said, yeah, we'll continue to block competition, and we will collect rebates from Novo and Lilly. And the insulin is discounted 60 to 80%. So you see these high prices, $500-$600 a month. The net cost is literally less than $100. And that's all the middlemen, wholesalers, pharmacy benefit managers, group purchasing organizations. They all make money off insulin. So if you were to take, I have one insurance company who's in the top 5. They make $3 billion a year off insulin rebates. Now, why would you? So they say, Mike, I would love to add Afrezza to my formulary. I'd love to make it preferred so that patients don't have to pay as much. But I lose $3 billion in rebates, and you don't have $3 billion in revenue to make up for me. So I'd rather block you and block innovation then provide people with a potential avenue to get better outcomes, right? And I've gone to these insurance companies. I've emailed some insurance companies saying, Mike, you could give me Afrezza for free, and I could not add it to formulary. Two of the largest insurance companies in the country.
That's insane.
Right? So this is the nature of healthcare. I talk about incentives. The perverse incentives aren't to get you to goal. They're not to make your life easy. They're actually to make money. And PBMs, they pick one or the other, pick Novo or Lilly. It's 50-50 market share between two companies, 95% market share. And why would you, if you go back to the whole pricing of insulin concept, think about it. You got 50% market share with one pharmacy benefit manager. I won't pick any of them. Just pick one. You make $2 billion in rebates. That company takes a 10% price increase each year. So now your rebates go from $2 billion to $2.2 billion, and you did nothing, and you just made $200 million more. And all you had to do was not change. And then the other company will come and say, hey, can I steal your business? And they'll go to the other company and say, hey, I might switch if you don't give me more money. And and of course the other company says, oh, well, I don't want to lose all that business, so I'll give you more money. And then the discounts go higher. And all of a sudden, nobody's making money in the mealtime insulin market. So Novo no longer markets mealtime insulin. Lilly's basically out of it. And they're all GLP companies now. You got Trulicity and you got Ribellus and you got, you don't hear mealtime insulin. Fios failed. They walked away from that. Lyumjev won't do well. It doesn't do anything differently. Not to pick on Lilly, but it's look at the results, guys. A1Cs, hypoglycemia, weight, all these things are basically the same. And we can all argue it works a little bit faster in the first hour. Well, what about this 5 and 6 hour tail that you deal with on insulin stacking and all that stuff, right? That's what
insulin stacking. Woo, look at you. I like it.
I had an endocrinologist tell me the other day, insulin stacking doesn't exist.
Okay.
This is your doctors, guys. This is the problem with healthcare. Insulin stacking does not exist. I go, are you
wow.
Me? Like,
yeah. This is
us.
That's the drug pricing. So Matt and Brandon, just so you know what I did, I got so fed up with society and everyone talking about they're dying, they're rationing insulin, all this stuff. Horrible to hear, right? I feel awful for patients. But I'll say two things about this topic. Number one, if human insulin, if you go back to the data, Humalog and Humulin or Novolin and Novolog, there wasn't a big difference in the clinical outcomes of those patients. There wasn't. And guess what today? Kaiser Health System here in California predominantly uses Humulin. They're still using vial and syringe for the majority of their patients. And guess what? Kaiser's outcomes are pretty much the same as national average. And they're doing it for 1/10 the cost. So when it comes to outcomes and cost, that's why Kaiser, when they charge me as an employer, half the price of Anthem or half the price of Cigna or United, it's because they actually do outcomes-based care. They actually incentivize their doctors to drive outcomes. And I know people, Kaiser, I'm just telling you, I think Kaiser has the model down. They're half the price of their competition. They're just going to keep growing nationally. They've got a great healthcare model. They measure their outcomes. Now, we'll look at this on the outside and say, oh my God, they're vial and syringe. I agree with that perception. But the reality is the outcomes are the same, right? And if this is really about cost and outcomes, they've got it down. I tell people $20 Walmart vials will generally work well for a majority of type 2s and some type 1s. Type 1s, you got a bunch of different other problems you're dealing with. And so I'm never going to fight that one, right? But generally type 2s, you just need to get enough insulin in the body to control the disease, and it's going to work fine for the vast majority of the population. And then when you get into Mannkind, so my first comment is like, we have human insulin. It'll work for the majority of people. It's cheap. People should try that if they're really having issues. And everyone will say I'm horrible for saying that, and I'll get blasted somewhere, I'm sure. But look at the data and use your evidence on facts, right? I just
blast you. We won't blast you, Mike.
You won't, but somebody will. Trust me, it's okay. I wouldn't be where I was if I wasn't somewhat controversial. The next one is Afrezza. So we are a premium product. You'll never hear me shy away from that. But we had to survive as a company. We almost disappeared, and Afrezza almost disappeared. So spending 20 years and $2.2 billion and then losing $130 million a year for a long time, we had to be aggressive on pricing and price changes to survive, right? This was a life or death. And if this product came off the market, no one's ever going to benefit. And we knew it's going to take time, to really get the cash flow break even for the company. But we also had innovation, and we can make a choice. We give up on diabetes and focus on other things. But we chose to fight the fight on both and not let the patient down. And that for me was when I came to this company, I did my own research and I saw all these patients' graphs online. They were unbelievable control. And I said, what did you do and how did you use the product? And I realized they used the product completely differently than we studied it. And that was part of the problem why we got the outcomes we got in our pivotal trials. And then I talked to the doctors and said, hey, if you can get these outcomes on these CGMs, why would you not use the product? And they gave me every excuse on why they will not adopt Afrezza. So my perception was patients win in the end, and if you do right by patients, then you'll be fine. Well, I didn't realize how stubborn endocrinologists are. So teaching old dog new tricks has been really, really hard. But people like you guys educating the world change life. And eventually more and more people get on the drug, doctors will see the results, and the rest will be history. So we have a little over almost 3,000 docs now using the drug. That's great. We'll get more. Every year we get a little bit more. But 97% of physicians have never written their first script that write insulin. So think about that. So when I think about the future, if I had 97% of docs write the drug and never wrote it again because it didn't work, I wouldn't be very optimistic. The reality is 97% of docs in this country who've written insulin have never written their first script of this product. So we got a long ways to go to educate the patients and educate the doctors, because you are pushing your doctor. Like you said, they're not bringing it to you. They're not thinking about it. And that's something we're continuing to do. And as our company grows faster, we'll have more money to invest to educate more people. And that's really one of the things we're going to do. And just to close out this topic of really access, right, in terms of patients having access to our drug, we launched a cash pay program in 2019. So I call it Earl Hirsch up in Seattle. And I said, Earl, you do all this insulin pricing. What's a fair price of insulin a day? Like you write all these scathing articles, which is fine. But what is it? He goes, no one's ever asked me that question. I go, so you talk about the price of insulin, but you never thought about what's a fair price for a life-saving drug per day. He goes, no. He goes, what do you think? And I said, I think it's $3 to $5. I think it's a Starbucks a day. To me, that's a fair price for a life-saving drug. And he said, I think that's fair. So we actually came out at $3 a day for a cash program in January of 19. And I went to the American Diabetes Association. I went to JDRF and Beyond Type 1. I said, hey, you guys are arguing about this petition. Can you sign it? Access to insulin, lowering cost. ADA, you got 600,000 people sign your petition. We see 60,000 consumers a month paying $200 or more for insulin. Can you just educate society that there is a $99 a month program instead of people paying $200 to $500? Can you just go out and educate that inhaled insulin has made the right decision to help consumers? Do you know how many of these nonprofits who represent patients? Nobody, right? And why is that? I don't want to take sides in the insulin pricing debate. I just want everyone to lower their costs.
Yeah.
Well, the way you lower costs, guys, is you create competition.
Hell yeah.
Right. It's 101. Let me go compete, educate society, raise awareness.
Everybody wants to take the new kids off the block, right?
And so we're the small guy. We're the disruptor. We don't have the money that the other companies have. We don't have the lobbyists. And so, the good news is we've survived through thick and thin. We're going to be fine now. But for the first couple of years, we're doing the right thing for patients. And honestly, I am very frustrated by a lot of the key stakeholders in this disease for not putting the patient first, for not driving better outcomes. And there's a T1D exchange data, if you've ever heard of it. But the T1D exchange came out and it said A1Cs are getting worse in the last decade than the previous decade, and yet we're using more technology than ever. So I'm getting ready for the pediatric study, and we're doing research for these physicians, and I would show their own data from the T1D exchange. I said, here's your group of 85 clinics, whoever's in this database. You guys are getting worse. Why is that? They all actually said that's not true. Most docs said, that's not true. I go, this is you're part of this database. Yes. You're the best centers in the country. So there's denial, right, guys? That's all I'm saying. There's denial about how well we're doing in society because nobody measures you. There is no public website on your success. And it's you as a patient guessing what's going right or wrong. The only disease I worked in my entire life where you are judged publicly is fertility. Fertility cycles and success rates in fertility are all on a website called sart.org. And so, and most 95% of people don't even know this, but you are judged as a fertility doctor on a website that's reportable to the government on your success and failure. How does that feel if you could look up your doctor's report card? You can't do that.
No.
I even went to a company to try to buy the A1C lab data so that I could make a website, and I was denied access to that data because they don't want someone to be able to compare doctors.
Wow.
This is so informative, and the information that you've given us and our listeners has been profound, right? This is the biggest interview that we've done with anybody, and we appreciate your time. We want to be very conscious of it. So I got one more question here for you, Brendan, and I are very thankful. You mentioned somebody outside of the U.S. Are you available where are you available right now?
Yeah, no, it's a good question. So we are only in the U.S. today and Brazil. So we went to Brazil. We're kicking off a trial for India as we speak.
Okay.
And we're excited about India, and we're looking at Australia and a couple other markets. But it's mainly a U.S. focus. We do have we have people in Germany and UK and buying the drug. So we've created a process for people to buy it. And a lot of times those governments will pay for it.
Yep.
And so, again, my goal is to help people around the world, but it costs a lot of money to go to Europe. And there's, just to give you some context on price, Turkey is $15 a month for insulin. Mexico is like $12 a month, right? So the price of insulin around the world is literally less than $20. And this is for 5 pens, guys, 5 Novolog pens. This isn't for like human insulin vials. Okay, so when you think about the $400 to $500 prices you see and the $15, we couldn't make our product that cheap to go to some of these countries. So
Right.
we're working on that, and as we get more success and as we get volume, the cost will come down. But at the end of the day, when we got a 300,000 square foot factory in Connecticut, it takes it takes $30 million a year just to run the factory before you make $1. So that's the reality.
Well,
Hey,
we
Mike,
appreciate the numbers that you've given us and everything, because it's very helpful for people to really digest what the landscape looks like and then where you sit in that landscape.
No, I know Matt said that was the last question, but I think he lied. He didn't know that I had one.
Eagles.
Eagles. You can't go wrong with that. Randall Cunningham or McNabb.
Yeah.
So how can members of the community learn more about Mannkind and Afrezza? I think that's the biggest thing. If they're not able to get to it by endocrinologists, we want you to go ahead and be able to plug that, so people can either do their own research and do their due diligence on it, or, maybe bring it up to an endocrinologist so, they can get involved.
I think number one, Afrezza.com has a lot of patient information. I know there's a leaflet you can download to ask your doctor questions. That's a great resource. Another avenue we're about to launch any day now is telehealth. So if somebody really wants the prescription, they're tired of waiting for their doctor, just dial in, $45 visit. You'll be able to go to telehealth and get a prescription through, can't say it right this second, but you'll hear a big pharmacy name very shortly. And so that'll be exciting for us next year, is really launching telehealth with an integrated solution where you just go in there. It's a one-stop shop. They'll deal with the PA. They'll route it through the pharmacy, and it'll come to your house in 3 days. So that's our goal, is to just simplify the streamline to healthcare, which I think anyone with type 1 diabetes, you live with the disease 500,000 minutes a year, you'll figure out how to dose the drug pretty quickly. You just need access to the drug, and that will help you. And if you have those questions, we have plenty of people here to help you. So Afrezza.com is one. If somebody's having reimbursement challenges, or there's always gonna be a prior auth, guys. So just like you do a PA for your Dexcom or your pump, no difference here. Sometimes you got to fight a little more, but that's okay. That 80% of people that have commercial insurance will get approved for Afrezza. So, we deal with the 20%, we appeal those with the patient and the doctors, but 80% of people that get a prescription will get Afrezza within a week. And that's important to know. So that's generally people have access. You just got to get the prescription, work with your doctor. And if your doctor has questions, we have a medical liaison team. We have a medical team. You guys can put my email out, whatever you want, and I'm happy to help anybody I can. But we have almost 100 people in the field calling on the doctor. So, the best is when a patient's denied by a doctor and they don't know anything. That's the excuse I hear. I said, look, let our rep go in and educate them. It's fine. But we're here for patients. We are a patient-centered company, and we will fight for care to transform diabetes. That's our mission. And you happen to call me today. We just announced our pipeline asset has completed almost completed 4 attributes to file the drug next year for a new disease called pulmonary hypertension. So these patients live taking a 20-minute nebulizer 4 times a day. And these patients are going to go to a 2-second inhalation on our platform. It's going to be transforming their life as well. So that's getting filed early next year. And we just got a big payment for that today. So
congrats.
I want to give a shout out. If
on that,
you knew that company, Martine, you think I'm a little crazy, and she's a phenomenally transformative human being. And she's, it's just another human being you could look at when you think about transforming things. She went from running Sirius XM radio and building it to building a drug company because her daughter got sick. So ironically, close out this great story today and the time with you guys is Al Mann's pump company saved her daughter's life because she developed this drug and had no way to deliver it. And she licensed the insulin pump in 1998 to deliver this drug called treprostinil, which saved her daughter's life.
Wow.
Transformed that company. They're now a $6 billion company. And then you fast forward 20 years later, we do a deal to help bring the next version of that drug into dry powder. So small world, pay it forward, do good in life, give back where you can, and more good stuff follows. So
that's amazing.
It's awesome.
Yeah, thank you so much for, first of all, for taking the time today to speak with us, but most importantly, what you've done for the community, individuals like Brandon and myself, people that live with diabetes all around the United States, and what you will be doing for them in the next couple of years. You got a couple of lobbyists right here. We're working on that for you. We got you, man. And, I think driven results it's just fact, right? People that use it and they can talk about it and they can put it out there. That's one thing that we'll continue to do for you because, this is just this life. Right? We live with this every day, like you said. So we appreciate it. Anything else you wanted to? Yeah.
No, I say, look, you got a good overview of Mannkind, inhaled insulin, a little bit of the background. I think there's another Maximus bolus conversation to happen around talking about bolusing and how we think about the timing of insulin and food. So let's plan another session at some point because I really love to share with you guys
sure.
and then talk about what it's like bolusing, right? I think that's a topic we didn't hit on tight enough, but that wasn't the goal for today. I really thank you for your inviting me to come participate and the questions here and your preparation for me. Give me some hard ones. I look forward to the next flip flop ones. So
yeah,
thank you, Mike.
as you can see, I'd rather be on a beach than anything else, guys. That's the beauty of California in the winter.
We appreciate it. So we'll say thanks again, and you can find this platform, find this on every platform that you listen to podcasts on, but probably already listening to that. So Michael, thank you so much for your time today, and we'll talk to you again soon.
All right.
Thank you.
Thank you.
As always, keep it 100.
Peace.
If you don't know, now you know. Bolus Maximus is not sponsored by anybody, but if you would like to get involved or sponsor a podcast,
please reach out to us at thebolusmaximus@gmail.com. That is the THEBOLUSMAXIMUS@gmail, or through our website, bolusm.org. That is www.bolusm.org. We also have an Instagram, Facebook, and a YouTube channel. Please feel free to reach out.